All right. So, hi everyone. Hello everyone. Am I audible? Yes, everyone. Am I audible? How is the audio visual? How is the audio visual, guys? How is the audio visual? All right. So, hi everyone. Hello, guys. How is the audio visual? Can I go ahead? All right. So, guys. All right. So, I think everything is fine. Audio visual, everything is going good, and we are ready to start. I think majority of the students, they have already joined, right? So hi everyone, this is Dr. Kashish Grover, your PSM faculty, right now. So this is those who are new, those who are watching me for the first time. This is for you. This is wind up 2, and today I am going to talk about the topics TB, NTEP, HIV, leprosy, NEEP, and polio. So guys, these are our topics for today, and these are the topics which we have already discussed in our quizzes, and now we are just winding it up so that any controversy or any query or anything you want me to explain again. So with this I am starting. So I have divided today's discussion in 3 sections. Section number 1 is let's analyze. So section number 1 is let's analyze. So in this section I will be discussing the questions which we did in the whole week, right? So question number 1. So going to question number 1. Question number 1 says a 45-year male with cough, more than 3 weeks, night sweats, fatigue, and unexplained weight loss. Sputum test confirms TB. He earlier took ATT for 21 days. So this patient should be categorized as, guys, the correct answer here is new case. Good evening. My good evening to all of you, bachcho. My good evening to all of you. A very warm good evening, bachcho. Because sometimes the chat is so many students are typing, I cannot wish you individually. So again, I am wishing you all a very good evening, right? So I'm going to take this session around 1.5 hour session. It is going to be there. It might exceed depending upon how much we are, able to imbibe, how much we are able to absorb, right? So just keep calm, just listen what I am saying, just participate, just recall with me, right? All right, once again, a very good evening. Now, so guys, this patient was earlier diagnosed as TB, but now again he is diagnosed TB. Still I am saying this is a new case. Why? Because new case is a case which came for the first time, or the patient is a previous case. The patient is a previous case, took ATT less than 1 month. So whenever a person consumes ATT but for less than 1 month duration, this is known as the new case. This is known as the new case, right? Now, okay, one student is asking me, video will be available after live? Yes, the video will be available after live, right? Okay, anyone having any other doubt before I proceed? Because I want to focus what I am telling you, because if I look at chat and if I try to reply you individually, I will lose some points which are there in my head. Any other doubt if you want to ask me? Video will be available after the live session, but I would recommend you to go live with me, because you can ask doubt, you go with the rhythm. Sometimes later becomes never. Okay, I hope no doubt. So I'm going, right? So once I'm done, I'll ask your doubts. I'll take your doubts also. Now, what is lost to follow up? Obviously, any patient who took ATT more than 1 month, but now I am not able to trace that patient. So the patient took 2 months ATT, but now not picking our call. He is not there at home also. Lost to follow up. I don't know where the patient went, right? Now, coming to relapse. Relapse means the patient took more than 1 month ATT. The patient took more than 1 month ATT. Now, earlier the patient became negative. So earlier when the patient took the treatment, the patient became negative, completed the treatment and became negative. But now again the patient is positive. This is relapse, right? Now coming to failure. Patient took more than 1 month ATT. The patient took more than 1 month ATT and at the end of treatment the patient never became negative, right? So this is the case failure. One more time. Less than 1 month, new case. More than 1 month, but I am not able to trace the patient, lost to follow up. More than 1 month, came negative during the previous treatment, but again came positive, relapse. Failure, took more than 1 month, but never came negative, right? Still the patient is positive after completing treatment. This is failure. I hope no doubt here. Right? Now, coming to the next one. Guys, now this is a bread and butter question for your FMG, for your NEET-PG and for your INASET. This is the bare minimum which we expect from you to remember. And from this, the pre-XDR is already a PYQ and it is not updated even in the recent textbook of PSM, right? Now, coming to monodrug resistance. Monodrug means, guys, HRZE, these are 4 drugs, except R, any resistance to anyone, either H or Z or E, except R, right? HZE, right? Now, monodrug, most commonly it is H. Now, RR is only rifampicin. Polydrug is more than one first line. Like H and Z, or you can say H and E, more than one first line. MDR is H and R. Now coming to pre-XDR, guys, this is first line drug. HRZE is first line drug. If I talk about group A, second line drugs. In group A, second line drugs, there are 3 drugs: levoflox, bedaquiline and linezolid. So pre-XDR is H and R plus levoflox or fluoroquinol. XDR is H and R plus levoflox plus any one out of 2 or both. Understood? So pre-XDR, H and R plus levoflox. So in this question they are giving isoniazid, rifampicin and levoflox. So what is the answer here? Guys, what is the answer here? Yes, the answer here is pre-XDR. Now, I am going a bit slow in first 5 to 7 questions because these are the questions which I was getting maximum doubts, right? Now, what is passive surveillance? What is intensified surveillance? What is active surveillance? Guys, I want you to set the chat box on fire, and I want you, all of you, to answer not this question. What is difference between active surveillance and passive surveillance? Just one line. I have already discussed in DVT and in my face-to-face classes. In Back to Basic also, we have already done it, right? What is active and passive surveillance? Leave this portion behind. Just with your knowledge, what is active surveillance? Very good, Manoj. Active is we go to house, and passive is the patient comes. Very good. Now guys, passive surveillance means now the patient is having cough and the patient is sick, came to the hospital, and we screened the patient for TB. This is passive surveillance. Intensified surveillance, the patient came to the hospital with comorbidity. Like the patient came to the hospital with COVID-19, the patient came to the hospital with TB, never for the symptom related to TB. Understood? So the diabetic patient came to me, and the diabetic patient came to me. I said, I want to screen you for TB. I want to screen you for TB. Right? So this is intensified surveillance. This is intensified surveillance. In reality, intensified is also a type of passive surveillance, because the patient is coming to my OPD and I am screening the patient. In reality, the intensified surveillance is also passive surveillance. Active surveillance, we are going to slums, we are going to the prisons, and now we are going at their doorstep to screen them for TB. Understood? So here, screening patient with comorbidities like diabetes, TB, this is example of, yes guys, this is example of intensified case finding. Intensified case finding. I hope we are also building the concepts, right? I hope many students, they were lacking in these concepts. I hope we are making the concepts as well. Best test for latent TB. Guys, what is latent TB? Okay, I want to tell you all that today is TB day, and we are discussing TB. Today is TB day and we are discussing TB. All right. Okay. सो जाओ करण. Okay. Okay, is it audible now, guys? Is it audible? All right, is it audible? Fine, I think it's fine now. Guys, please write in the chat box, is it audible now? All right, so the theme for this year TB day is yes, we can commit, invest, yes, we can, and deliver. Now what is coming back to latent TB infection? What is latent TB infection? Latent TB is a TB infection where we are not getting symptoms, where the patient is not getting symptoms, right? Where the patient is not getting symptoms, but the patient is having TB infection. For this we have two tests, IGRA and tuberculin test, which is known as Montague's test. The problem with tuberculin test is sometimes it is positive with BCG. When the history of BCG is there, sometimes it is positive. So among them, IGRA is a better test. Now, dose of rifampicin for FDC tablet for drug sensitive TB. Guys, for drug sensitive TB, we have HRZE and the dose is 75, 150, 400 and 275. This I am talking about adult. The children FDC is 50, 75, 150, 100. How to remember? Double it. This mnemonic, today only one student told me, sir, this is the mnemonic, right? Now, so the rifampicin 150. Now, how much monthly incentive given for Nikshay Poshan? Guys, 1000 per month. Now, 1000 per month is the rate, but in account 3000 for 3 months. 3000 for 3 months. In account 3000 for 3 months. IGRA. Okay. It is not immunoglobulin beta, it is interferon gamma. IGRA is interferon gamma, not immunoglobulin. Right? Okay. Now, coming to TB supporter. If it is a drug sensitive TB, 1000 will be given. If it is a drug resistant TB, 5000 will be given. TPT supporter 250. TPT supporter 250. Now, guys, I want to tell you one point. Please listen to me. This travel allowance, guys, there is one new information here. There is one update here. It was earlier 750 to tribal. Now, if a patient drug sensitive or drug resistant coming from a hilly area or a tribal area, rupees 750 one time. A new update, guys, I am telling you a new update here, and the new update is if the patient is drug resistant TB, in that case 400 given if the patient is traveling within district. So the hospital and the residence of the patient is in same district, and the drug resistant TB is coming to the hospital for the treatment or the follow-up, right? Then 400. 1000 if the patient is going to other district for any kind of complication, right? The patient is going to other district, like suppose a TB hospital is in other district. This is update, guys. This is update. I have not told you earlier in my classes. This is an update. Now, sir, why 3-month timeline for Poshan, not more or less? Sonal, the government says like earlier, Sonal, earlier the government was giving every month, like 500 every month. Then the government said, okay, we will not give you 500 every month because clerical work and the account transactions are there. So government said, we will give you at the rate of 500 per month, 1500 in every 3 months. But then government increased the amount. Now government says 1000 every month, but in your account you will get once in a 3 months. So 3000 every 3 months with the rate of 1000 per month. With the rate of 1000 per month. Virapamil Verapamil is saying what is TPT? Tuberculosis preventive therapy. Tuberculosis preventive therapy I have discussed in my classes, beta. TPT I have already discussed. Asmita, yes, another update. Asmita, 750 is there for all TB, drug sensitive, drug resistant, but from tribal area. Asmita, it is for only for tribal area. Yes, Asmita, we have 1 or 2 more updates. So here the correct answer is 1000. Okay, I think we should increase our speed now. TB pleuritis, guys. Okay, guys, what is pulmonary TB? Pulmonary TB, when the lung parenchyma is positive. When the lung parenchyma is positive. The problem here is, why so many updates? Because TB हारेगा देश जीतेगा. Pratiksha, TB हारेगा देश जीतेगा. Here sputum is positive and it is communicable, right? From the droplets, from the droplet nuclei, from the aerosols. But the extrapulmonary is here the other than lung parenchyma, which includes pleura as well. So TB pleuritis, extrapulmonary TB. Verapamil was asking about TB preventive regimes. Verapamil, there are TB preventive regimes. What are they? Number 1, 6H. Number 2, 3HP. Number 3, 1HP. Number 4, 4R. And 6 levoflox. 6 levoflox. 6H means 6-month isoniazide. 6-month isoniazide daily. Here 3-month isoniazide plus rifampicin. If these two drugs you give for 1 month, it is 3 HP. If you give for 1 month, it is 1 HP. But the only difference here is it was once a week and it is a daily regime. So daily isoniazide and rifampicin 1 HP. Once a week 3 HP. Now 4R 4 months rifampicin and 6-month levoflox. Again daily. So I don't want any kind of confusion in this. There is nothing like, right? There is nothing like 6R, right? There is nothing like 6R. Now minimum duration of BPAL regime is 6 months. What is BPAL? Bedaquiline, pretonamide, linezolid, moxiflox, and it is not given less than 14 years. Less than 14 years of age, BPAL regime is not given. This BPAL regime along with MDR can be used for pre-XDR, right? In pre-XDR we give BPAL, right? Now TB, all the updates, all the questions which we discussed, we are done with that. 1-2 updates still in TB, don't worry. All right. Now guys, when the follicles are less than 5%, when the prevalence of follicles are less than 5%, antibiotics are stopped. Antibiotics are stopped. If it is more than 5%, we give antibiotic, facial hygiene, environmental cleanliness. When it is less than 5%, we give facial hygiene and environmental cleanliness. Now the S of safe strategy Sonal till treatment is going. It is not once. Nikshay portion is till the treatment is going. Okay, I have one question. I have one question for you, and the question is, if the patient is taking treatment from a private sector, TB positive patient taking ATT from a private sector, do you think the patient is entitled for Nikshay Poshan Yojana? Quickly comment in your chat box. Yes or no? Just two things I want you to comment. Yes or no? Yes or no? Quickly, guys. Quickly. Yes or no? I want yes or no. Manoj is saying no. No, yes. So any patient taking treatment from public sector or private sector, they all are eligible. Any TB positive patient, even taking treatment from private sector, they are also eligible. Now, coming back to this question, so here it is less than 5%, so F and E, we need facial hygiene and environmental cleanliness. Guys, not true about tetanus. The source is soil, the reservoir is soil. Human to human transmission is not seen in tetanus, only it is soil to wound, right? Human to human, it is not seen, right? You must be confusing, sir. What about neonatal tetanus? What about neonatal tetanus? What about maternal tetanus? So that is during the procedure of the childbirth, when earlier the dai and the home deliveries, they used to use the contaminated, right? Asmita, that point says, okay, you guys are confusing between 2 points. Asmita, here we are talking about trachoma follicles. Saurabh sir told me that day also. Better you write the full form of TEF and TS, otherwise students, they will be confused. TF, here we are talking about, here we are talking about trachoma follicles, right? Trachoma follicles, right? But less than 0.2%, you are talking about trachoma, that is trachoma trichiasis, right? So बच्चे, जब भी हमें, whenever we have trichiasis more than 0.2%, it is better we plan the surgical corrections. Here this 5% guideline is for TF, trachoma follicles. Very good beta, you have already written now trachoma trichiasis. Done? Sorted? Asmita bachche, sorted? Can I go ahead? Yes, Karan, now it is eradicated. Okay, now one student was asking, guys, now during quiz you are asking, sir, why dirty, now you see, now you really see this is a clean wound? Do you really think this is a clean wound? This is not a clean wound. This is not a clean wound. See, is this a clean wound? Really a clean wound? This is not a clean wound, right? This is not a clean wound. This is unclean wound. And in case of unclean wound, where the last tetanus, they are not sure about it. They are not sure about the tetanus, last tetanus. Better give TT and immunoglobulins. Better give TT and immunoglobulins. Very good, Dr. Manoj. Very good. Even if you have a clean wound and the patient is coming after 6 hours, it becomes unclean wound. Good. Very good, Manoj. Very good. Now, many students were confused in this question as well. Many students, they were confused in this question as well. Guys, see, if a mother is pregnant within 3 years. Many students said, sir, pregnant within 3 years, there is no need to give. Guys, no, that is not correct. I don't know from where you have read. Less than 3 years, one booster is needed. More than 3 years, 2 doses are needed. 1 month apart. Right? So here, 2-year-old child. So that means the pregnancy is within 3 years. So only one booster. Only one booster. Guys, TD. Okay, I am telling you here again. Now, this TD contains diphtheria plus tetanus. This is given to pregnant women. But TT, only tetanus toxoid, this is given in case of trauma. So, mnemonic here, T is for T. Mnemonic here, T is for T. Right? T is for T. Right? Now, sorted? Guys, one more query I want to address here. This DT, this TD, what is the difference between? What is the difference between DT and TD? This DT, the capital D, it contains large dose, usually given to children. This small d, it is a small dose. Usually we give for booster in adult. We give booster in adult. Now, it's been like 2-3, not 2-3 years, around 1 year. Around 1 year. A student asked me, sir, we are told that TD we are not using these days, we are using DT. You call Kashish Grover or you call Grover Kashish, one on the same thing. They both are same. TD and DT, they both are same. They both are same. There is no difference between them. In India, sometimes we say DPT, but in US they say DTAP. Diphtheria, tetanus, acellular pertussis. Right? So if you call DPT or you call DTP, they are same. If you call TD or you call DT, they are same. The only difference here is small d and capital D. Understood? No. So this kit is a red kit. This is for acyclovir, and please do learn the mnemonic which I have told you, the mnemonic for each. Now updated kit, the brown kit is updated kit. It is kit 8. This is for anorectal discharge, and the drugs are doxy and cefixime. So this is wrong. Doxy and cefixime. Now coming to HIV, duration of infant ARV prophylaxis. Guys, if nothing is mentioned, just mark 6 weeks. If nothing is mentioned, just mark 6 weeks. If they have mentioned that murder is a high risk case, if they want to go in depth, right? If they want to go in depth, then only you go in depth. Otherwise, from birth to 6 weeks, we give ARV prophylaxis to the infant. Guys, it is best within 72 hours. It is said as soon as possible, right? As soon as possible. Now, preferred regime for PEP in adults. This is tenofovir, lamivudine, dolutegravir. Even in pregnant women, we prefer this. Even the patient is HIV TB co-infection. In that case also we prefer TLD. Why TLD? Because D is having very good viral load suppression. 8-year-old with 25 kg weight, first line ART. Guys, what is your answer here? 8-year-old, 25 kg weight, first line ART. What is your answer here? guys, this is the screenshot from Government of India guidelines. You see, age less than 6 years, we give ALL, abacavir, lamivudine, lopinavir, ritonavir. And this update came in 2021. This update came in 2021. After 2021, there is no update here. I am teaching this from last 3-4 years, right? From last 3-4 years, even in my last year quizzes, last year quizzes, we were following this guideline. This is the only guideline for first line ART to be followed in India, right? Now, 6 to 10 years or weight 20 to 30 kg ALD, abacavir, lamivudine, dolutegravir. Now, if it is more than 10 years or body weight more than 30 kgs, it is TLD, tenofovir, lamivudine and dolutegravir. Now guys, this is pre-exposure. They are not same. First line ART and PEP regime, they are not same. Here we have TLD. Now children more than 6 years of age, right? We have ZLD, and less than 6 year or less than 20 kg, we have ZLL. This is the most updated, most recent guideline. If you see anything other than that, then I don't know about that. I only know what is there. I only know what is the most reliable source. That is Government of India guidelines. So I don't want any kind of controversy now. People living with TB on ART and ATT. So guys, whenever we have a patient ATT and the ATT contains rifampicin, we give TLD, continue TLD, but so guys, TLD dose is 50 mg, but you give another 50 mg extra. So if a HIV patient is with you, you give 50 mg dolutegravir. But if the patient is also TB positive and consuming rifampicin ATT, you give 100 mg plus 50 extra. Guys, I'm not kidding, but this is recent FMG question. So if this is a recent FMG question, you know FMG questions, they have very much potential of being asked again in NEET-PG. So this is very important. I don't want you to mess up with any kind of TB HIV guideline. TB HIV leprosy, one question is definitely, even in your INSET exam, I really don't want you to mess up with these guidelines, right? Now, sorted. This is PEP regime, right? Now, so this is the Government of India guideline again. Whenever we have a TB HIV co-infection and we give extra dolutegravir, but if we have any protease inhibitor, any PI, right? Now in that case, we do not give rifampicin. Any PI, we do not give rifampicin. Whenever we have a PI like efavirenz, we replace rifampicin with rifampicin. Okay guys, I understand I am going slow. Till now I am going slow because TB HIV is important and I don't want you to mess up. But from now I'm going to increase a little bit speed. Okay guys, again this is very important. Listen, I don't want you to mess up in this. Cotrimoxazole. Guys, cotrimoxazole. Everyone, please focus. This is very important. You cannot mess up with this. Right? So the question is, Mrs. Kava is HIV positive and she gave birth to a baby girl. Which of the following is true about cotrimoxazole in the newborn? Start at birth and continue till clinician wants. Is nowhere mentioned in any guideline, and it is not followed in any of the treatment protocol. It is not the wish of the clinician. Clinician cannot have the food as per his or her wish. How can he give you treatment as per his or her wish? Right? So, cotrimoxazole. Now, if at birth of baby with HIV positive mother, you start cotrimoxazole at 6 weeks. And give till 18 months. Guys, few months back I took a session for the pediatric residents, right? And I was discussing these guidelines there. In that session also I mentioned why we are starting cotrimoxazole at 6 weeks, because these babies, although they are negative at this point, but they are at very high risk of developing pneumonia and diarrhea. We do not take the risk. We start with cotrimoxazole. We give them till 18 months. Now, at 18 months, we check for HIV status. If the patient is negative, we stop cotrimoxazole. If the patient is positive, okay, I am hiding myself. If the patient is positive, you continue till 5 years. You continue till 5 years of age. Okay, guys, one more time. A baby born to HIV positive mother, but still the baby itself is negative. Still we will give till 18 months. Right? Still we will give it till 18 months because pushti of infection, the surety of infection comes at 18 months only. Right? At 18 months, if the baby is negative, stop cotrimoxazole. At 18 months, if the baby is positive, you continue cotrimoxazole till 5 years. Till 5 years, you continue. At 5 years, you go and check for CD4. If CD4 are less than 350, continue cotrimoxazole. If they are less than 350, you stop it. Okay, I'm sorry. Just, I'm sorry. Okay, tongue slip, guys, tongue slip. No tongue slip. I have written correct. Here I messed up. If more than 350, you stop it. If less than 350, you continue. Okay. Are we good so far? One more time. If a baby born to HIV mother, start cotrimoxazole 6 weeks. Continue till 18 months. Till at 18 months, check positive or negative. If the baby is negative, you stop cotrimoxazole. If the baby is positive, you continue cotrimoxazole till 5 years. Does it depend on CD4? Till 5 years, it does not depend on CD4. Right? It does not depend on CD4. Yes, Asmita, very good. You have added another point. Very good, beta. Very good. Sorted? I think it's sorted now. Right? Now, a man presents with 2 lesions and thickened nerve. Guys, this is a case of multibacillary. Because in multibacillary, even one nerve is multibacillary. If a leprosy patient comes with one nerve involvement, earlier one nerve was paucibacillary, more than one was multibacillary, but from 1st April 2025, even one nerve is multibacillary. Okay, so guys, I know so many guidelines, so many questions, so many information, and I know a bit boring subject, I know a bit guidelines, but can I still see some happy faces? Can I see some fire in the chat box? This will give me a message that yes, you are attentive, you are able to learn it, and I am going to make a difference in your preparation. That's it. Can I see some happy faces in the chat box just to know you guys are awake or slept? All right, so few happy faces are there. Good. Now coming to the next one, guys, this is a blister. Here 3 drugs are there. In this blister 3 drugs are there, and we use it for less than 6 months. For less than 6 okay, not less than, for 6 months we use it for paucibacillary. 12 months we use it for multibacillary. So it is used for both now, right? It's used for both pauci and multi, both. Guys, this question is important. Leprosy, NEET is so important, and still I feel bad when students ask me about this. So guys, when I give this question, students think this is something related to ASHA incentive. Guys, this is a whole program for leprosy, right? Now, whenever ASHA suspect any case before disability, we give 250. The government gives 250. And if ASHA suspect after disability, okay, Asmita is saying the pink tablet is for adults and brown is for kids. Yes, this is correct. So B for B, right? B for B. Brown is for bacha. Good mnemonic. So before disability, before disability 250 rupees, and if the ASHA is able to detect the case after disability, 200, right? ASHA gets 200 rupees. Now, focus leprosy campaign, we conduct this campaign when we have a single case of grade 2 disability. Grade 2 disability, single case of grade 2 disability. Leprosy elimination, less than 1 case per 10,000. Less than 1 case per 10,000. Guys, NEET-PG 24, FMGE 25. This question came. So the given image, this is Sapna mascot. This is Sapna mascot, and this is for spreading awareness about leprosy. Spreading awareness about leprosy. This logo is for NEEP. This logo is for NEEP. The rising sun. Here we have a rising sun. This indicates home. This is lotus flower. Lotus flower indicates hope. Rising sun. Lotus flower indicates purity. No, Asmita, only grade 2. No other campaign for grade 1. And this gives hope. Incentive given to leprosy patient. Guys, whenever we have a leprosy patient and it is disability, and the patient is having disability, now we want the patient to get the surgery. So we give incentive to the patient for the surgery, right? Because the patient is going through the surgery to correct the deformity, and the patient is going to lose some wages. To recover the wages, we give 12,000. Earlier, old guidelines said 8,000. Right? A real-time reporting software for leprosy is NEET. This is for NEET. Now, primarily, polio is an infection of human alimentary canal. Around 80% cases, they only feel diarrhea. In some cases, the CNS is involved. Guys, switch. Okay, listen to me. Listen to the story. This is important. This is important. Switch. P1, P2, P3. In the OPV, we have P1, P2, P3. Guys, the P2 case, the last case of P2 came in 1999. Right? 1999. And this P2 is also causing VDP. It is also causing, this is the most common cause for VDPV. What is VDPV? I'll tell you in next slide. Right? So it is most common cause for VDPV and last seen in 1999. So there is no point in giving it in OPV. That is why from trivalent OPV we switched to bivalent OPV. It is P1, P2, P3. It is P1 and P3. It is P1 and P3. So what do we withdraw? We withdraw OPV2. Note a key difference between IPV and FIPV. FIPV gives more immunogenicity. Dr. Karan, it was 2016, not 2015. More immunogenicity. Now, IPV and OPV, IPV can be used in controlling epidemics. No. Only OPV can be used in controlling epidemics. Right? Now, guys, this VDPV is of three types. Ambiguous VDPV, immunodeficient VDPV, and circulating VDPV. This circulating VDPV, it behaves like wild polio virus. It behaves like wild polio virus. Now, VDPV is most commonly seen with OPV2. How to remember VDPV? D means dual, that is 2. Alright, so these are all the questions which we discussed in the quiz, with all the explanation, with all the updates, with all the important information. Manoj, we are planning to remove P3. We are planning to remove, but till now, no. Now, guys, here I have given you all the important images at one place. So we have already discussed, only this is MCR, microcellulose rubber footwear, in which patient you give leprosy. In which patient we give leprosy. Right? So this is TLD. This is TLD. All the images. So regarding the current session, these are the images. And guys, 2 updates I want to give you on TB. This is 99 dots. This is for adherence. This is a portal for adherence. Right? This is portal for adherence. So what is there in 99 dots? Muskan, yes, BPAL is for MDR and pre-XDR. But BPAL M is given in MDR. So the patient is consuming this tablet. The patient opens the flap and there is a telephone number written over there. The patient calls the telephone number and the bell, it rings up. And once it rings up, we have to give the missed call. And after they say thank you, we ask the patient to disconnect the call. So once they say thank you, it means the system updated that you have taken the drug, right? Now this is the update which I want to give you. MERM, Medication Event Reminder Monitor. This is important for INSET. This is only for MDR TB. So this is a box with the device connected here. When the patient opens the box to take the medication, the automatic updation in the NEET-PG portal happens that this MDR case opened the box and consumed the drug. Right, so this is only for MDR, guys. This is only for MDR in selected areas. Not everywhere. All right, so we are done with the questions. We are done with the important images related to our block 2. Now coming to the rapid fire. Yes, we are about to end this session. The rapid fire. Bache Ori is asking, do we need to know about B-PAL regime, guys? Obviously, pharmacology of B-PAL is important. The pharmacological aspect is very important. I have only covered the public health aspect, right? B-PAL is important. I repeat, B-PAL is important. If you have attended my last INSET November, the discussion which happened on DAMS Delhi YouTube channel, I told you about B-PAL and 10 most important questions I discussed, and one of them was B-PAL, and B-PAL came in INSET. Right, this is important. Those who know me, last year I told you diphtheria. I told you sapna. These two questions came in your NEET-PG exam, right? So please, whatever I am saying, just whatever I am saying right now, try to follow it, try to learn it, right? Okay, rapid fire. Are you ready for the rapid fire, everyone? So the rapid fire round means we have fill in the blanks, and everyone has to answer. Everyone, you have to answer, right? Can I go for the rapid fire? Everyone, can I see some fire in the chat box? Yes. Now let's start. Barometer of social welfare. Which disease is known as barometer of social welfare? Tuberculosis. What is pre-XDR? H and R plus fluoroquinol. What is XDR? H and R plus fluoroquinol plus bedaquiline or linezolid. TB solid culture. LJ media. Liquid culture. Bactec or MGIT. Latent TB infection. IGRA and Montux. Nikshay Poshan Yojana 1000 per month. Most common causing VDPV. P2. Elimination of leprosy, less than 1 case per 10,000. ARV prophylaxis, nevirapine for 6 weeks. Nevirapine for 6 weeks. So this is the rapid fire round, and with this I end this session here. Thank you so much. I tried my level best to cover all the important aspects in this block 2. What next? Now we have block 3 schedule. By tonight I'll give you block 3 schedule, right? A humble request, try to give live quiz, because when other students are also giving it with us, it also gives us a moral boost. And keep giving the quizzes, keep attending the quizzes, keep studying. Thank you so much. Thank you so much. If you have any doubt, you can ask. Thank you so much, bachcho. Thank you so much. I tried my level best to compile this for you. Thank you so much. If you have any doubt, I am going to take your doubt. Sunil Reddy, 9 p.m. The time for quiz will be 9 p.m. 9 p.m. daily. Sometimes I get occupied. I will update you if there is any change, but daily it is going to be 9 p.m. Some days if I'm traveling or if I'm occupied somewhere, I will update you. Vatsal, yes bache, B2B 3 revisions done, and keep on giving the quizzes, because this time I'm also adding, right? Now any other doubt? Udbhav, already I have given BPAL important points about BPAL in the Telegram group. Manoj, vaccines, the live vaccines are not given in pregnancy. In that case, no. Hareen K, in that case, no. So that incentive in tribal area, 750. So lead time and critical path method, this is not related to today's topic. Muskan, we will do this. PSM sorted hai? Yes, Sakshi, PSM sorted hai. Thank you so much. Alright, I think it's time to end the session. If you have any doubt, feel free to ask your doubt. Yes, if specifically vaginitis is mentioned, right? No, the red color or the pink color is used for paucibacillary these days. Whatever you are mentioning, it is not. Green blister is not used nowadays. Okay, Vatsal, we'll do these multiple sessions. Alright everyone, thank you so much. Keep studying and don't forget to give the quizzes, right? Don't forget to give the quizzes. Thank you so much. God bless you.